morning. Okay. And all of you here, all your fine or? All your fine. Okay. And the current year 5 or coming year 5? And your last posting, when will be your last posting? This is already April, isn't it? Exam July, isn't it? So your last posting will be? Huh? June? May. Okay. What I will do today is to brief you, since exam is coming, okay, how you prepare for the exam, okay, and how you behave during the examination, okay, and what expectation of an examiner, okay. Then expectation of the examiner is not only for your knowledge, your skill, but your attitude, okay. I'll give an example, okay? Long case, okay, long case you are given 1 hour to the patient, okay. You spend 1 hour, organize your talk, within that 1 hour, and you organize how you're going to present your history, medical examination, investigation. So when you arrive, when you're going to the room of examiner for the case, you're already prepared. How are you going to present history? How are you going to present physical examination, investigation, and management? You can write down. You can read even. Okay? You can read even during the in front of you. Okay? And then usually the invigilator or whatever invigilator will ask the examiner whether you are ready to go in, and please knock the door. Okay? And of course greeting the examiner. Okay? And don't sit down until the examiner says please sit down. Some of you just grab the door, get the chair, and sit down. This, because you want to develop rapport with the examiner. That's very important, okay? To make that examiner is like you on that within half an hour, isn't it? Okay? The examiner like you within half an hour, okay? We don't want examiner hate you during that within hour, because when they start to hate you, okay, it's stingy. The examiner will be stingy with the mind. Okay, when they like you, okay, simple mistake, they just smile and close the eye. Okay, so that's where develop rapport and good communication with examiner. That's one. Okay. And during that day of examination, prior to day of examination, I think you just forget it, whatever preparation, sleep early. Okay, and go to the exam hall, okay, with the best dress or clothes that's possible. Okay, clean, in other words, okay. For the boy, at least polish your shoe. Use the sock. Okay, I can see that some of the boys not even using the sock, and the shoes is not polished. Okay, we don't expect a new shoe. We don't expect a new shirt either. And use the clean, if you are wearing like coat, okay? Use a very clean, okay? Like without stain, all that, okay? Because appearance, okay, will present what's your inside. Okay, so that is okay. And then today session is objective is how you present history, how you present physical examination, how you plan investigation and management to the examiner. And you would do the same thing when you are out to the hospital. No different at all. Doesn't mean that you have license now to treat patient, you can do everything. No. Continue whatever you learn, whatever your behavior, your method during the during the exam. Continue to do that. Okay? And continue to do that until you have finished the houseman and you enter the postgraduate program, whatever, you register the postgraduate program. It's the same. It's the same. Undergraduate and postgraduate. But the issue is that when you become a houseman, you think that you can do everything, you develop bad behavior, bad side skill. And you tend to shortcut all that, okay? auscultation without prior percussion, for example. Okay, so so that is don't let go your basic clinical skill. Okay, those already in my class, okay. At this stage, okay, you present only relevant history, relevant physical examination, okay, appropriate investigation and management. Okay, and so how do you know that your history, your physical examination, and your investigation level? Okay, you must have some technique how to double check that my history is relevant, concise. Okay, with patient in front of you. Okay, and you can develop many techniques. Okay, simple one that I use myself. Okay, okay. What you do is from the history. You start from history. Okay, you will have chief complaint. Okay, for example, chief complaint is left chest pain. Okay, very history, sudden onset. Okay, associated with difficulty in breathing, all that. And then from there, from brief history, you must have idea what's possible diagnosis and possible differential diagnosis. Okay, I give example. For example, left chest pain. Okay, patient with diabetes or patient with hypertension. What else? Ischemic heart disease, isn't it? But don't just occupy with ischemic heart disease and doesn't think about others, because there are other causes of chest pain, left chest pain, difficulty in breathing, like pulmonary embolism, pneumothorax. Okay, sometimes patient with GERD can present with chest pain. Okay, sometimes with respiratory distress. So from that brief history, you can try to get appropriate differential diagnosis. 4 or 5, something like that. 4 or 5 differential diagnosis. When you have differential diagnosis now, okay, you can ask relevant history to the patient. Okay, and try to avoid direct question. Try to go around and try to get the question. For example, I keep remind you how you get history of taking painkiller. For example, you don't ask patient, you take painkiller, because patient will take scared of you. Say no. So you go the other way. For example, you have a joint pain. You know, elderly, you have joint pain. Yes, I have joint pain. What do you do when you have joint pain? Yes, I go and bought a medication in the pharmacy. The painkiller. So that is how. Don't that unless you're really desperate, you still cannot get that, and you can use the direct. Okay, so from different diagnosis, now you can ask many questions. Okay, you want to rule out pulmonary embolism, you ask 1, 2, 3, 4, 5 questions. You want to rule out GERD, there are specific symptoms. Okay, you want to rule out ischemic heart disease, there are few symptoms. Okay, of course you must know, you have some knowledge about clinical features of that disease. Okay, and then let's say after done all different diagnosis, you must arrive possible provisional diagnosis. Let's say you arrive to provisional diagnosis of coronary artery disease. Okay, and remember, component of diagnosis consists of pathophysiology, anatomy, etiology, and complication. Don't just diagnosis is acute coronary syndrome. It's not complete diagnosis. Acute coronary syndrome just block of coronary artery. Okay, component is pathophysiology or anatomy. Isn't it? What are the components? Etiology, complication. Okay, etiology here. What possible etiology? More of the contributing factors: hypertension, diabetes mellitus, hyperlipidemia, lifestyle. So that and then you go for complication. What are complications of ischemic heart disease? Heart failure, for example, arrhythmia. So you go for that. So when you say that diagnosis acute coronary syndrome, contributing factors is diabetes, hypertension, complicated with heart failure, then complete diagnosis. Okay, that's how you go about. Okay? Okay, some chronic disease, for example, patient with lupus nephritis, for example, patient coming with joint pain, hair loss, all that, patient on chronic treatment. You ask also complication of treatment. Okay, patient on steroid, what are the complications? Of course, you must know the features of Cushing syndrome, and then only you can. So then your street is very complete. Okay. So the next step is you go for physical examination. And problem with many students or even postgraduate, you disconnect between history and physical examination. The history and physical examination should always two-way communication. Two-way communication. Sometimes finish history and then got something in physical examination. You go back to history. So most of the time in medicine, about 98%, you can get diagnosis, different diagnosis in history. You need only another 5% to support from physical examination and investigation. So, physical examination is, if you don't disconnect between history and physical examination, what objective of your physical examination is to confirm the provisional diagnosis and to rule out differential diagnosis and to rule out complication. If patient on complication of the disease and complication of treatment, if patient on chronic treatment. Okay, so that is the purpose of physical examination. So, for example, is patient with ischemic heart disease. So, general examination is okay. Patient in pain, for example, a patient complain of pain. Okay, and etiology, you look for risk factors like tendon xanthoma, okay, xanthelasma, arcus finalis. Okay, that's and then complication, you go for the past, for example, for any irregularity of what. And you examine the lung to rule out the heart failure. Okay, so that's the purpose of physical examination. Purpose examination is to verify your history. Okay, same thing. Investigation. You have to prioritize the investigation. Not anymore blood investigation, imaging investigation, urine investigation, not anymore. Okay? The purpose of investigation is to establish the diagnosis and to rule out differential diagnosis and to rule out complication of the disease and treatment. Okay? So, when the examiner asks you, well, let's say patient has ischemic heart disease, okay, how are you going to go about it? Don't say that blood, I want to do HB because low hemoglobin can precipitate ischemic heart disease. No. So why investigation? ECG, isn't it? Simple. So how you prioritize is non-invasive, simple, cheap investigation, but can give the answer. Okay? So that's how you prioritize. Simple, cheap, non-invasive, okay, but can address the diagnosis and differential diagnosis. Chest X-ray, for example, simple, cheap, okay. So that's how you prioritize the investigation. Okay, don't answer that I want to do blood investigation HB because of of course relevant, but is it the priority of investigation? You do HB, can you diagnose ischemic heart disease? Can you diagnose heart failure? No, isn't it? But you can do that later on. But because patient came to hospital with 100 ringgit, with that 100 ringgit, you want to address the diagnosis, you want to address the you want to do investigation, and then 100 ringgit also, you get the treatment. You don't spend 100 ringgit for investigation and nothing for treatment. So that is, okay. Okay, at least now you get some idea, okay? And don't forget to give summary at the end of your history of physical examination. Don't wait, examiner asks you. And remember, his summary is, I keep remind you, history only one or two sentences only. Don't repeat the whole history. For example, this patient with background of diabetes, hypertension, came in with left chest pain, with difficulty breathing. Who stopped that? How many sentences? One sentence only. people who listen to your summary without listening the full history, at least guess what's going on with the patient. That is summary. But problem many of you, you takut tak complete, you give another one paragraph of 5 lines, 7 lines, all that. No. Okay, that is summary. Okay. Okay, that apply now, that what I have told you just now, okay, to the real case. Who going to present the case? Okay. Nama apa? Isha. Isha, okay.
So, Assalamualaikum and a very good morning to Prof and everyone here. So for our long case session today, I have prepared a case clubbed yesterday. So, okay. So for my case, I would like to introduce my patient. He is Mohamad bin Hassan, a 53 years old Malay male, lives in Batu Empat, Tunjung, works as a vegetable seller at RTC Tunjung, has underlying of hyperlipidemia, allergic rhinitis, bronchial asthma, diagnosed since 2010, and he also has ischemic heart disease, which currently is on restriction of fluid 1 liter per day, and has multiple recurrent admission for unstable angina, and he also has recent admission for community-acquired pneumonia, previously in March 2025. So this patient is presented with worsening shortness of breath with cough for 3 days prior to admission. So for the history of presenting illness, my patient was initially well until 3 days prior to admission when he started feeling feverish after he went back from visiting houses during Hari Raya. It was a high-grade fever and it was continuous throughout the day. He has no chills or rigors, no night sweats, no runny nose, and also no sore throat. And he suffered no UITI symptoms and no GI losses. He then developed a dry cough, which was sudden in onset and short bouts. The cough was persistent throughout the day and exacerbated when in cold temperature. For example, it was raining that night and the patient mentioned that the exacerbated cough had woken him up from his sleep. He then experiences shortness of breath during coughing. However, there was no chest pain, but the patient had to sleep with 2 pillows. Patient 1 had also mentioned that the patient had been snoring during his sleep, and when he was having those shortness of breath, he had to take 5 to 6 puffs of inhaler to relieve the symptoms, and then he continues his sleep. The next day, he woke up feeling lethargic and he was unable to have a comfortable sleep, However, the cough still persisted with a similar presentation as the day before, and then he experienced another episode of shortness of breath during coughing when he was resting on his chair during the day. He then took another 5 to 6 puffs of inhaler and then he rested the whole day. He mentioned of unable to talk in full sentences, and he only talked in words which are comprising of 3 to 4 words in a sentence. And then on the morning of admission, he then experiences another shortness of breath. That night, he was also unable to sleep as he had woken up as he had another episode of shortness of breath, and he had taken another 65 puffs of inhaler that night. And then on the morning of the admission, he then experiences another episode of shortness of breath during coughing, which he claimed to be worse than the other days. He took another inhaler puff, but the symptoms still persisted and has not resolved. Otherwise, there was no radiating chest pain, no chest pain during inspiration, no teary sensation, no hemoptysis, no constitutional symptoms. And then this patient also has no history of trauma. He also has no history of sick contact and then no history of TB contact. He previously had recent admission last 3 months ago in January 2025 and also was just discharged 2 weeks ago for similar complaints. Both admissions are treated for community-acquired pneumonia. So that's for patient history of presenting illness.
Can we stop there, okay? Okay, those listen to the history now, okay? What are the possible differential diagnosis? This patient. Yeah, please. Huh?
Exacerbation of bronchitis.
Okay. Anything else? Anything else? Huh? What? COPD. Okay. Ini ada differential diagnosis. Huh? Yeah? Bronchitis. No history to suggest that. Any other? Community acquired pneumonia. Lagi? Huh? Heart failure. Isn't it? Lagi? Lagi? Habis dah? Okay. It's okay. At least that's what I want. You arrive to possible differential diagnosis. The issue now, have Isha attempt to rule out that differential diagnosis? That's the issue now. Isha, have you ruled out possible acute exacerbation of asthma? As she said, one of the differential diagnosis.
Not. I did rule out. I did rule out the acute exacerbation of bronchitis because I did not mention the frequency of the attack and also.
Dengar ada belakang? Dengar? That's why I asked you to go. I don't like to use the mic, okay? Okay? Apa dah?
I think I haven't ruled out acute exacerbation of bronchial asthma full because one is that I have not fully said about the frequency of the attack, shortness of breath attack, and then there is no triggering factor that can suggestive of bronchial asthma, and then history of atopy.
Is history of?
Atopy.
What?
Atopy.
Atopy. No. That one later on. That takes you want to go etiology, isn't it? But have Isha attempt to rule out this is acute exacerbation of asthma. How typical patient with acute exacerbation of asthma? Presenter. Sudden onset, acute difficulty in breathing, apa lagi? Ya? Chest tightness, ada apa lagi? Ocular breathing, apa lagi? What the nature of the breathing? What patient with difficulty in breathing due to asthma? Noisy breathing, isn't it? That's very important, isn't it? Noisy breathing. And then you go to any possible precipitating factor. Okay? So that's one. You try to rule out acute exacerbation. I'll come back to how to present this case. Because Isha, I think how many times presented with sudden onset of difficulty breathing, use bronchodilator or present. And then if patient has 20 times onset, are you going to present like that too? In exam. Or even you do that in the part in front of your NO. That's how you irritate. Not you irritate examiner, you irritate your superior, your boss. So you must know how to present, okay? Okay, before you go there, why you ask history of night sweat, apa lagi? Constitutional symptom. Isha, why?
Because it's chronic condition, so I was trying to rule out TB.
But she just told that how long history? 3 days. Patient with 3 days difficulty breathing, you want to rule out TB? No fever? Why is it you know history of UTI? This is what I mean. What I mean. No such routine anymore. You're talking about in front of patient. You think that's not right, no need to mention. Faham tak? No need to mention. But you take the history, keep to yourself. If someone asks you, does the patient have constitutional symptom? Then you can answer. Because you think that it's not relevant to mention. Because patient presented with very short history. It's unlikely the patient had tuberculosis. Okay? No UTI. Patient no fever. Why you expect? Why you mention that? Because you still carry on the word routine. But what I want you to message is must be relevant to this patient. Okay. Does Isha try to rule out congestive cardiac failure in history? Isha, have you attempted to rule out cardiac failure in history? Yes or no? Yes or no? No. Eh? Yes. Swelling apa lagi? Effort tolerant. Have you mentioned effort tolerant? Apa lagi? Wake up at night. Mention tadi. Okay, wake up at night. Power. Wake up at night. Apa lagi? Okay, fever air. Okay, so that's possibility. Okay, apa lagi? Because patient with heart failure can present exactly like acute exacerbation of asthma. And this patient the right person to develop heart failure, isn't it? Because patient have hyperlipidemia. And patient have background ischemic heart disease. Isn't it? So you must rule out heart failure. Okay? Okay, let's say don't go for the other, but let's say you think that from that history you arrive to possible diagnosis of acute exacerbation of asthma. Okay, okay. Another one is that here is another diagnosis is COPD lah. COPD. How old patient? How long lagi history? No, history of recurrent episode of recurrent acute onset of difficulty in breathing. Because recurrent acute onset of difficulty, there are many different diagnoses, isn't it? Apa dia? Acute exacerbation of asthma, acute exacerbation of COPD. How long the history? Recurrent pulmonary embolism also can present recurrent difficulty in breathing. Apa lagi? How long the history? Apa?
This history has been going on for 10 years.
10 years. Okay, possibility of acute exacerbation of COPD. Okay? Okay. Okay, good. Now you arrive to acute exacerbation of asthma. Okay, I want to, don't want to pay. Asthma. Okay, when you arrive here, what are the other things that you need to fulfill? Okay, acute exacerbation asthma is a complete diagnosis? No. So, you have to bring here, this one, here. Because acute exacerbation asthma is just a pathophysiology. Okay, so you must know what is specific, what is the cause. Here is precipitating factor. What are the complications? Okay? Okay. So, in this case, what are the precipitating factors trigger this current episode? Aisha? You are what are the symptoms you are TI depression?
He was having fever, and then also having cough.
Okay, cough. Okay, cough with what color is sputum?
No sputum, dry cough.
Dry cough. Okay. Okay. Let's say just I throw you in there. Let's say the patient have yellow sputum. What that imply? I ask you in the exam. How you going to apply? Who already got undergo my class? Patient with brown eczema, yellow sputum. Hands up. Siapa dia yang dah underwent medicine? Yellow sputum, what they imply? Patient with acute exacerbation asthma. Eosinophil, isn't it? Green sputum is bacteria. Okay? Yellow sputum in patient with acute exacerbation asthma because of eosinophilia. So many eosinophil in the sputum. Okay? So sometimes examiner will ask you, but you can answer that. You impress the examiner, you got extra mark. Okay? Okay. So you think that you are TI. Okay? So that's it. Okay. Anything else that precipitate asthma? In this case. Of course, you have to go that later on, history of atomic history of LG. That's later on. Okay, that later. Okay. 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 And then, possible complication of treatment. What patient with asthma will be on chronic? What form of treatment of patient with asthma? That. What complication treatment that you are interested? Yeah? Steroid, isn't it? So whether this patient you must ask history complication, easy bruising, recent weight gain, okay, difficult to stand up from squatting position, indicate a proximal weakness. So that is history of complication. You try to rule out everything. Okay? So you can put that. Now, when you have that information, you can put that consistent. Okay? Acute exacerbation of bronchial asthma precipitated by upper respiratory infection, UTI. Okay? Okay? Complicated with tak ada, zero. But complicated treatment, for example, is steroid side effect. If, for example, just give an example. Okay? Do you have some idea now? Okay. Okay, Isha, continue your history.
Okay, so for the past medical history, this patient has ischemic heart disease. First attack was in October 2020 when he was brought to the emergency by ambulance because he had left-sided chest pain from.
Okay, before I walk it, how you present this case? Okay. What you present is this patient with background hyperlipidemia and ischemic IDA and a bronchial asthma presented with recurrent acute onset of difficulty. Okay? And then the attack is characterized by 1, 2, 3, 4, 5. Sudden onset, noisy breathing, precipitated by, okay, and how often the attack? Every week, every month, okay, and how often he has used a rescue inhaler? Huh? How often he has used a rescue inhaler? Huh? Okay, so does this patient using rescue inhaler bronchodilator during the system breathe? Huh? Okay, does this patient have prophylaxis inhaler other than bronchodilator? That's very important. Don't wait. Don't wait until in the history of medicine history. You can put it because it's relevant. Yeah. Why it's important to know it? Because if patient with asthma has to use rescue inhaler bronchodilator 3 times, 4 times a day, that's what that means. Not control. Okay? And many people, okay, use prophylactic inhaler as a rescue inhaler. That you must ask also. When you use steroid inhaler, that's another one. That is common mistake. Okay? That's because our fault also, we don't explain to the patient. The steroid inhaler has to use regularly, 2 or 3 times a day. But bronchodilator, use when if necessary. Okay. What time that patient, this patient wake up in the morning, at night?
2 in the morning.
2 in the morning. Okay. If patient with asthma wake up in the morning with noisy breathing, what that imply? Huh? What that implies? Nothing like morning dipping. Huh? That implies also the asthma is not well controlled. When 2 or 3 o'clock in the morning, when the air is very humid, it tends to precipitate. Okay, we don't want morning dipping with patient asthma. So that history is very important. Okay, you don't read that from. Okay, what patient do for living?
He sells vegetable. I
How often he miss to sell vegetable?
He does not miss.
Huh? Do you actually also he will go and sell vegetable?
If we went there, then that's it, because he sells together with his wife.
So that's very important. If children, for example, how often he absent from school? Okay? If those working in whatever office, whatever, how often he has to take MC because like that. So that is information. It's very important. Okay, simple asthma, but that is the information that we need to have. And I'm sure 2 or 3 of you will get case of asthma and acute exhaustion of COPD. So that information is very important. Okay? Okay. Another one is, does the patient can exercise normally?
He memang tak exercise.
Okay. So another one is whether this is exercise related asthma or not. And when you say exercise, you can access that effort tolerance also. Okay? So in this case you can say that this patient with background of hypertension, okay, hyperlipidemia, and bronchial asthma presented with recurrent acute episode of difficulty breathing. Okay? And the episode is characterized by acute onset, associated with nausea breathing, precipitated by symptom of runny nose, fever, cough, something like that. Okay? Okay? And he have how often? When is the last episode? Okay? How often have to use bronchodilator? Okay? And he said patient was epidemic until 3 days when patient again have sudden onset of difficulty breathing associated with nausea breathing, and this is precipitated by symptom of running nose, fever. So tak payah every episode you want to explain. Okay, so that's how you present. If patient have recurrent episode, similar episode, it tend to occur if patient with heart failure, tend to occur patient with bronchial asthma. Because I know that in the exam, okay, many of you 10 episodes you describe the same thing. If this same episode cancel, recurrent episode, 10 episodes so far within that 1 month, 1 year, and describe. The episode is characterized by 1, 2, 3, 4. Okay? Okay, so Kak Wanita start early?
Pass medication.
Okay, pass medication.
Okay, so continuing on the presentation for this patient past medical history, he has ischemic heart disease. First attack was 5 years ago, which was in October 2020, when he was brought to the emergency by ambulance because he had left-sided chest pain, compressive in nature, radiated to the back. It was associated with profuse sweating, palpitation, shortness of breath, and also poor effort tolerance. The symptoms were temporarily relieved by taking sublingual GTN, however, still persisted afterwards. Investigations were done, and then the attending doctor told him that he is treated for unstable angina due to his normal blood results. And he had another single episode in June 2021, also treated for unstable angina. And then recent incident of heart attack was 2 years ago in December 2023, where he had loss of consciousness at home. Initially, he had gone to the bathroom to take the bath as he was feeling uncomfortable with the excessive sweat he was having. He was also having palpitation with dull aching chest pain, and then he suddenly collapsed and then lost his consciousness. Upon arriving at the emergency, he regained his consciousness, and then there he was treated for unstable angina and failure, and then was put on restriction of fluid for 1 liter per day. And then upon further asking, patient claimed to be compliant to the restriction of fluid, and then he was planned for angiography, however did not proceed with
So can I stop here? Okay. Patient with coronary artery disease, heart attack, you restrict the fluid. So what that imply? Patient doctor that advise restrict the fluid. So your duty now is try to rule out why a doctor asks to restrict the fluid. Don't just stop there because it's patient with ischemic heart disease, we don't ask to restrict the fluid unless complicated. So now, Isha, what problem with you? You swallow whatever patient tell you, okay? And then you vomit out to me, okay? But that is it. That is it. Your duty now. If you think that is not right, find out why doctor ask you to restrict the fluid. Does he have difficulty in breathing? Have reduced effort tolerance, for example. You have ankle swelling, for example. Okay, that's only. So that's how you go about it. Okay, must be a reason. Doctor asked you because patient with whatever heart attack, you don't have to see. Like this case also, 3 episodes, isn't it? You don't need to repeat 3 episodes. Say depression like 3. Okay, 3 of acute myocardial infarction, whatever lah. Okay, 3 episodes of acute coronary attack. Okay, the attack is characterized but the last one associated with, which was 2 years ago, associated with loss of consciousness or whatever. Okay, so how many center? Okay, here.
Okay, so for the medications, patient is currently on tablet cardiacin, 100 mg OD.
Apa dia?
Tablet cardiacin, 100 mg OD, and then sublingual GDN taken PRM. So for the...
That's all medication.
That's all the medications.
Okay.
So for bronchial asthma, so patient had late onset of bronchial asthma in 2010, but he is not on any proper follow-up, and there's also no history of intubation.
How was the asthma diagnosed?
Because he had multiple admission due to similar complaints of shortness of breath precipitated with URTI.
The patient was diagnosed with asthma 10 years ago when he presented recurrent episode of shortness of breath precipitated by upper infection. And
then patient has allergic rhinitis, has history of atopy, which was allergic rhinitis, and his recent asthma attack was 2 weeks ago, which was in March.
how do you know that patient has allergic rhinitis? Because patient told you.
Patient told me.
Cannot, isn't it? You must find out. If I told you I have allergic rhinitis, you want to believe it? No, so at least you must know the symptom. What are the symptoms of allergic rhinitis? So, allergic rhinitis was diagnosed. Patient has recurrent of running nose, apa lagi? Sneezing, lagi apa lagi? Block, lagi apa lagi? Huh? Headache, isn't it? Because block, isn't it? In back, okay? So that is okay, kira. Apa lagi?
So for hyperlipidemia, diagnosed during the initial.
What was treatment for allergic rhinitis?
Allergic rhinitis, he is on. He only took antihistamine that he bought from pharmacies.
Okay. How? Okay, I just ask it. I don't want to forget. How relation between asthma and allergic rhinitis?
He hypersensitivity.
Yes, hypersensitivity. Okay, apa lagi? Yeah.
Inflammation.
What?
Inflammatory response.
Yeah, of course. What is relevant of patient with asthma at the same time have allergic rhinitis?
Atopy.
Yeah?
Atopy.
Yes, allergic atopy. What other relevancy? It made asthma difficult to control. You need to treat both. Okay? So one of the reasons that patient have recurrent episode because of allergic rhinitis, which is not treated properly. Okay?
So this patient also have allergy towards antibiotics, fluoxacillin, and also EES.
What? Fluoxacillin? Okay.
Noted antibiotic allergy during his multiple admission due to URTI. However, I could not get detailed history for this because patient.
Okay, family history.
For family history, both parents have diabetes. Both parents are. Sorry. Okay, so for family history, both parents have diabetes mellitus. Unsure of the control, but both have already died due to old age. And then he is the third out of 6 siblings. His first 2 sisters has diabetes mellitus, also on follow-up. However, her
So what is
first
the most relevant family history in this patient?
no history of asthma,
Ya, asma apa lagi?
no history of heart disease,
No, oh yeah, apa lagi?
and then no
What skin disease?
of it will be
Eczema.
eczema.
So that is okay. Social history.
Social history. Social history. This patient sells vegetable with his wife at RBC Tunjuk
You
Market.
mentioned, no need to mention again, okay?
So this patient was a chronic smoker for 38 years, started since age of 12 years old. He has stopped smoking 4 months ago with his own initiative and has not relapsed since then.
Why stop? What's the reason to stop smoking?
Niat dia.
Huh? Yeah.
He was adamant to stop smoking lah. Previously, he had multiple attempts to stop smoking already. And
Any event to make him to stop smoking?
no,
Okay,
he mentioned.
okay. Anything other in social history?
Okay. And then previously he mentioned he would smoke 3 boxes of cigarettes in 2 days, and has multiple attempts to stop smoking before, and was also on stop smoking clinic follow-up.
Any other social history other than smoking?
No, he is not an alcoholic drinker. He's
No, not relevant.
Oh, closing area.
How the house condition?
House condition. House condition was well equipped and also
Well,
well equipped.
what do you mean by electric? Water electrical supply.
He has carpets in his living room, but he does not have any pets. And then his housing area, I'm not sure how to mention it.
How far the house from main road? Why?
I did not ask that.
Why is it relevant?
Because of the smoke
Dah, sudah. So that one lagi. Okay. Apa lagi? Social history. Ya, industrial area ni tidak. Quarry particular tu ni. Apa ni tidak? Pet, any pet?
No pets.
What pet?
Cats.
Any tidak? Ada pet? Bird tu ni.
Oh, but he does bird keeping as well.
Ah, see? So that is my history. Okay? I don't ask how distant attached bathroom double story, but patient with heart failure, then you ask that, but the patient is because that's relevant social history. Very important. Because you want to advise the patient. Okay, summary now, Isha. Summary.
So this patient is a 53 years old Malay male, has a line of hyperlipidemia, allergic rhinitis, bronchial asthma since 2010, and has ischemic heart disease on restriction of fluid.
What's that? 53 years old, okay? With background of history of bronchial asthma for 10 years, okay? Presented with recurrent episode of acute onset of difficulty which lasted so 3 days ago. I mean, stop, isn't it? Okay? Okay, physical examination.
Physical examination. Okay, so
Physical examination.
for this patient, on general inspection, this patient was he has a moderate body build, lying comfortably.
Why you present moderate body build first?
Okay, so what I thought is on generally what I see on the
Tak
patient.
tahu boleh lah. What is patient complaint?
Patient complain, shortness of breath.
That's the first thing you should answer. That's what you want to sell, isn't it?
Yes.
You want to sell a car. You don't go give the worst part. The best part you want to sell, isn't it? So sama lah ya. Patient with sudden onset of difficulty in breathing. Patient not in difficulty in breathing. Patient with chest pain. Patient not in pain. So that's the first thing, okay lah. Ni body pain buat apa? Okay lah.
Okay. So on general inspection, this patient is not in pain and also not in respiratory distress. On inspection, he was lying 45 degree, in supine position, supported with one pillow, and he was also alert to time, place, and also person. And his hydration and also nutrition status is clinically adequate. He was not cacaxic, and there's no. He is fit.
Why cacaxic? Ni bodybuilder ni cacaxic. Okay. I tried my duty that try to dig as many mistake Isha as possible. Not purposely. I try to dig out as many mistakes as possible because now you are at this stage you have license to make mistake, million mistakes. But please don't mistake when you deal with the patient. Okay. So my duty here to dig out. But don't feel I try to okay.
Okay. So this patient is pink and there is no presence of peripheral cyanosis.
Okay.
So for vital signs.
Hold on. Okay. First physical examination is general examination. General examination. Difficulty in breathing. Patient with acute exacerbation asthma, mental function is very important. Because you want to assess the severity of acute attack. So, what are the parameters, Isha, that to assess the acute severity before touching the patient? What are? Whether this attack is acute or not acute? Respiratory distress, apa lagi? Alert is very important, apa lagi? Alert lah, apa lagi? How do you assess severity of asthma before touching the patient? By general looking. Yes, talk je ni. Okay, apa lagi? Apa lagi? Color je ni. Okay, well, patient cyanosis or no? So that is not even touching the patient. Okay? And you said that this patient cough. Not productive cough. Okay? So how you prove that? How you prove that? Yeah? Yes! Sputum port is part of physical examination. Okay? There's no sputum port, there is sputum port but it's empty, for example. Okay, so that is part of physical examination. Not only patient but it's site. Patient with diabetes, patient, and then does the patient have inhaler on the side? Side table? Does the patient have steroid inhaler on the side table?
No.
This is part of physical examination. Okay, that is part of physical examination. Patient with asthma. Classically, patient with atopic, they have plastic flower instead of the live, but no more now, isn't it? Okay. Before that, okay, one of the indication that the patient that allergic to pollen is they put the plastic flower. The family give the friend present plastic flower, not the real flower. Just but not anymore. Now, okay. So clear. So the physical examination is not a patient. When you expect a patient, not only you expect the patient, you expect the surrounding. Okay. Patient with diabetes, any glucometer, for example. Okay. Patient with TB, whatever, sputum cup. Patient with asthma, inhaler. So don't stop that patient only. Okay? Surrounding also is part of physical examination. Then only you want to touch the patient. Okay, carry on.
On the surrounding there is presence of nebulizer.
Yeah.
Yeah.
That's clinical finding. Okay.
So for his
Another one is history of nebulizer. Okay. Many of you, I give nebulizer for this patient to relieve the acute asthma. Is it right statement? Huh? I give nebulizer to the patient. Nebulizer is a machine, isn't it? So you nebulize the medication. Because you nebulize, the patient won't respond, isn't it? You nebulize. So then I will prescribe nebulize bronchodilator to this patient. Okay, come on. Ya, apa lagi?
Respiratory rate was 25 beats per minute, and then blood pressure was 110 over 80 millimeter mercury. Pulse rate was 90 beats per minute with regular rhythm and then good volume. Temperature was 57 degrees. And then for SpO2, it was 35% under WAN. And then on peripheral examination for his hands and arms, both palms were pink, warm, and also moist. There is no finger clubbing. And then
Okay, Syah. Okay. The most important here when you diagnose problem, even touching, you must look at the parameter. What are the how severe that is. How you assess after general inspection just now, talking, colors, all that, the what are the parameter in when you touch the patient to indicate severity of asthma? To assess the severity. Yeah? What vital sign? Okay, apa lagi? No, apa lagi? Pass. What is a pass? Wow. Okay, no, I'll come back to you. What is the pass? Tachycardia, isn't it? Okay. Nature of the pass, no. Kuat sikit. Dengar tak belakang? Kuat. You stand up and shout to them.
Pulses paradoxus.
Okay, one of the sign. Okay, tachycardia. Okay, pulses paradoxus. Okay, stand up. Tell what is your understanding of a pulses paradoxus?
Said the pressure is dropped more than 10 millimeters of mercury, like it's deeper than exaggerated deeper.
With?
Inspiration.
Yeah, isn't it? So, isn't it? Okay, acceleration or the drop of blood pressure. Okay, that's why paradoxus. Okay, weak acceleration. Okay, that is a sign of severity of okay. Okay now, so that is a anything else. Isha mentioned clubbing. Is it relevant here? Huh? Why you mention clubbing, Isha?
it's because this patient has underlying heart disease.
So what disease is this patient? Ischemic disease have clubbing. Huh? So the message I want to hear that any sign that you want to mention that you must have justification. No routine anymore. Okay? No routine. But of course you examine. But you think it's not relevant, no need to mention. Okay, no? Okay, hand apa lagi? Pass. Any passes paradoxical apa lagi? Okay. Capillary apa lagi? Okay. So have you finished with the general examination? Apa lagi?
Face examination.
Okay. What face examination?
His sclera was pink and also conjunctiva.
Yes.
Sclera was pink and then conjunctiva was not clear. And then his oral hygiene was also moist and then not coated, some not coated.
I just ask, okay? Why you mention jantan not coated, moist, oral moist? What?
Allocation ada increase in giving bukan kegiatan dry or because of
Yes. So you should answer that to assess the hydration, state of hydration of the patient. Because patient with asthma tend to have dehydrated. So the message that when you measure something, you must have reason why. It's relevant. But I just to ask you whether by mentioning that, whether you know that what there is the purpose of mentioning. Okay? The patient tend to hydrate. So that's why one of the reason patient do not respond to bronchodilator because of thick mucus due to dehydration. So the bronchodilator won't reach the airways. So it's your duty to assess the state of the attack that is relevant to this patient acute attack of bronchial asthma. Correct? Apa lagi? General assessment, apa lagi?
neck examination.
Pada.
His trachea is centrally located.
Okey, apa lagi?
Lower
JVP. Apa lagi?
JVP
Kita
was
ada.
raised.
Koyuteral hak apa lagi?
And then he carried pulse.
Lowering swelling
Lowering
saja.
swelling.
Okay. So what system nak you take examine? First,
Respiratory.
respiratory. Okay, tell me respiratory.
So on respiratory examination on inspection, the chest moves symmetrically with each respiration, and then there's no gross deformity, no chest wall deformity.
What gross deformity? What do you mean? What gross deformity?
Factors skeleton, factors carrying.
You expect adult with asthma expected what abnormality?
Hyperinflated chest.
How do you know that the chest are inflated? What inspection? Huh? What do you mean by barrel chest? Yes, increase HP diameter. That is okay. At this stage, I don't want you to mention no chest deformity anymore. But I ask what chest deformity, you don't know. Patient with asthma is in adult onset is you don't expect factors like cardionatal but you expect increase HP diameter. Because that's available. Because of hyperinflated lung kan eh? Kira. Apa lagi Syah?
So on palpation. So on palpation.
Brachial you mentioned already mentioned, okay?
And on palpation, the chest expansion was good, adequate. And then tactile parameters was also normal. Apex piece was not displaced. And then on percussion, it resonates symmetrically. Then on auscultation,